Hello friends, welcome to the recall session of NEET 2023 March 5th exam. I know all of you are waiting to get a recall session because this time it was really confusing, right? So if you get one more recall session, your confusions may go a bit down, right? When I asked the students about how were the questions from NEET this time, the response was, very ma'am, this time it was so easy. We learned a lot, but only few topics were there. One is alcohol, then nutrition, that means especially the vitamin deficiency, and lots of congenital syndromes. And the response was like so simple. But afterwards, when we started discussing, they were like, oh my God, there was a catch. So this could be wrong. And then the response changed. It was not that easy. Okay. Now let's see few questions. What you guys said were right. When I got all the questions, when I compiled all the questions, a lot of questions from nutrition, lots of questions from syndromes, and only little bit from epidemiology, and those important topics were kind of ignored this time, but don't expect that all the time. Okay, so let's start with the first question. A worker in a cement industry on chest x-ray showed mesothelioma. What could be the cause? When you see, this is a question from occupational health. When you see cement, your first impression is, okay, so cement, maybe silicosis. But here the answer is not silicosis. What is the answer here? There is a point which, or there is something which point towards the answer, which is mesothelioma. So mesothelioma is seen in? Yes, it is seen in asbestosis. Okay, so in asbestosis, it is mesothelioma, because you know that asbestosis exposure can lead to malignancy. Not only mesothelioma, it can lead to CA brown gas, GI malignancy, it can lead to malignancy. So here the answer is asbestosis. And in silicosis, a very commonly asked MCQ, which is the X-ray appearance that you see in silicosis, it is S and S. It is snow, storm appearance. And what are the other appearances that you see? You will see peripheral calcification of thoracic lymph nodes, which looks like this. What do you want to call this as? Can you make out this? This is eggshell calcification. Again, another thing that you see in silicosis, also known as ball of wool appearance or snowstorm. Okay, and snowstorm is a very commonly asked MCQ usually, but didn't come in this exam. And asbestosis, like I said, it can lead to malignancy. So when you see malignancy, pneumococcosis, that is asbestosis. And bagastosis is because of sugarcane. Anthracosis is because of coal dust. And the MCQ from anthracosis is, it is known as black lung. Anthracosis is black lung. So anthracosis is black lung. It is black lung. That is also a favorite MCQ that usually comes. Okay, moving on to second question. A 10-year-old boy has developed fever with rash. On examination, very simple, Koplik spots were present. What is your diagnosis? Whenever you see Koplik spot, fever, rash, without any doubt, you can go for the answer, which is measles. This was very simple question. And in measles, Koplik spot appear as a prodromal symptom around 2 to 3 days before the rash appears, and it is pathognomonic of measles. Will you identify Koplik spots? If you see one, like you can see here, they appear on the buccal mucosa as white spots in red base. And this is how they appear. And this is a previous image-based question. Another MCQ, let's go through all those important MCQs, which are important not only for NEET, but in INICT, in FMG, in everywhere. This is important. So let's also discuss few other points which come in and around these topics. SSP, subacute sclerosing panencephalitis. I hope you know that. This is a rare complication that you see in measles, which appear in 1 per 1 million, usually. Now starts the questions from vitamins and nutrition. And alcoholic patients with global confusion, ataxia and ophthalmoplegia has presented to OP. What is the cause for the disease? Patient has got global confusion, ataxia, ophthalmoplegia. So that points towards, yes, it points towards Wernicke-Korsakoff psychosis or syndrome, right? And that you see in alcoholics due to thiamine deficiency. So that is the answer, thiamine deficiency. Now let's see what it is. Okay, you can expect few other MCQs from this. Of course, it is due to thiamine deficiency. You see that in alcoholics. And what else? It is actually a neurological disease caused by the lack of thiamine, right? Lack of thiamine. Now, what is it? Actually, this Wernicke-Korsakoff psychosis is a combination of two different conditions which you see as two different spectrum in one particular condition. Okay, so it includes Wernicke's encephalopathy and Korsakoff's amnesic syndrome, okay, which are different stages of the same disease. And it represents the first one, that is Wernicke's encephalopathy, that represent the acute phase of the disease, and Korsakoff's amnesic is something which is happening afterwards. It represents a chronic or long-lasting stage. Now, what happens in the first stage? There is a degenerative brain disorder due to lack of vitamin B1, due to not only because of alcohol use, one of the major causes, of course, alcohol use, dietary deficiency of vitamin B1, prolonged vomiting, eating disorders, and effects of chemotherapy. All these can lead to Wernicke's encephalopathy. So don't only think in terms of alcohol. When a patient is coming to you, you have to rule out other causes as well. Don't just brand this person as could be alcoholic. Okay. And it damages brains, thalamus and hypothalamus. That is why these symptoms are happening, like mental confusion, visual problems, coma, hypothermia, then low blood pressure and lack of muscle coordination. And in Korsakoff, it is a kind of memory disorder. That is why, see, amnesia. Okay, that result due to vitamin B1 and is associated with usually alcoholism. It damages nerve cells in brain and spinal cord, and it impairs memory. So the patient usually presents with amnesia, tremor, coma, disorientation and visual problems. Okay, so all these signs and symptoms somewhat coincide, but you have to understand that Wernicke's is different and Korsakoff is the late stage of that. And vitamin B1, that means providing vitamin B1 is the treatment, and you have to provide proper hydration. Now let's see the second question. A child presented with dermatitis, thinning of hair, alopecia. On asking, the mother is giving history of eating raw egg for a long time because the child was not gaining weight. So the mother was giving, raw egg for a long time. Which the following vitamin deficiency can cause this? The points are, this is a vitamin which is needed for skin and hair, because there is hair loss, there is dermatitis, and this vitamin is related to eating raw egg. So the answer is yes, biotin, right? Biotin is good for skin and hair, and biotin is lost when you eat raw egg. Now, what is happening? What is the problem with eating raw egg, especially the white? When you consume raw egg, that will give to biotin deficiency. You know how? Because this contain something known as avidin, which tightly binds to biotin, thus making biotin unavailable for the use by the body. So, when you cook egg, that kills avidin or that denatures avidin, and the bioavailability of biotin will be there. Okay, so that is why it is advised to cook egg and eat, and never to eat raw egg. In some places, I'm not very sure, but I heard that people who go to gym, I don't know, I heard that they are advised to take raw egg. I heard it. Okay, anyway, that's not a good practice. Next question, identify the disease condition mentioned in the following image. Very, very simple. Very much expected question. On seeing such questions, you feel so happy. I know the answer. So, what is the answer? What you see here is rickets, right? This is rickets. This is rickets. And rickets is because of vitamin D deficiency. Okay. Now, let's see few other two image-based questions from rickets. Rickets could be either genu varum or genu valgum, right? So, what is this? Is it varum or valgum? This is genu varum. Okay, this is genu varum. Whereas valgum is knock knee. Okay, so bow leg is genu varum and this is genu valg. Easy to remember. Just remember this gum. Gum is for sticking things. So, the knees will stick together. So, that way you can remember. And what is another manifestation of vitamin D deficiency? Is it only rickets? No. It can also cause osteomalacia. Now, I'll show you another X-ray picture from osteomalacia. What do you call this condition? This is the previous question. Anyway, we are discussing NEET 2023. So, let's also discuss other previous year questions which came in 2023. What is this? What is your diagnosis? This one. These are pseudo fractures which run perpendicular to the affected cortex. What do you call it as? This is known as Looser-Zahn, which is typically seen in osteomalacia. Okay, so this is, can you make out? I think here it's a little more clear now. This is known as Looser-Zahn seen in osteomalacia. Both these are MCQs. Okay. Now moving on to the next question. A poor farmer whose staple diet is rice and pulse have developed spastic paraplegia. All in that village, that means everyone in that village are walking with stick. What could be the cause? I don't think everyone will be walking, but that is how the question came, is what I got from the recollection. Anyway, what is the answer? By the way, spastic paralysis, walking with stick, eating pulse. So, this is pointing towards, yes, this is neurolathyrism. Due to, which is the toxic principle? Beta-oxalyl aminoalanine or simply BOA. Beta-oxalyl aminoalanine. Okay, it is beta-oxalyl aminoalanine or BOA. Okay, so this will be the typical appearance of person who has neurolathyrism. So there is 1 stick stage, 2 stick stage, you know that, right? Crawling stage. So those things are there. I'm not going into those details. You can expect this as an image based question also, and it is because of eating dash kesari dal, right? Kesari dal. And the toxic principle that we have already seen is BOA, beta-oxalyl aminoalanine. Now coming to the prevention of letharism. There were 2 questions from letharism. One was regarding the prevention and next was the toxic principle. Prevention of letharism is vitamin C prophylaxis. Is mentioned as something which will help to prevent letharism. Next is banning of the crop. Okay, just ban the crop. Removal of toxin. Either by steeping method or by parboiling, you can remove the toxin by steeping method or parboiling. That is also another MCQ. How can you remove the toxin? Then educating the people not to take that. Then genetic approach where you are trying to replace that with a less toxic dal. Okay. And then socio-economic changes. That means you improve the socio-economic status of the people so they don't have to depend on this particular crop. Okay. So these are the methods of prevention. And the question came, which this time from prevention was, see, which vitamin is used for prevention of neuroletharism? Vitamin. There is nothing without vitamin, right? It is vitamin C. All questions, majority of questions were from vitamin C. So that covers 2 questions from neuroletharism. Okay, a child is presented with inflammatory rashes on face, perioral and perianal region. What could be the diagnosis? Actually, I tried but I didn't get other options, so I have just written the answer here. It is acrodermatitis enteropathica, which is because of deficiency of or deficiency due to zinc. It is due to zinc deficiency, another deficiency. Okay, so in acrodermatitis, I'll show you image-based question which you can expect. So these are the manifestations. Okay, so inflammatory rashes on face, then perianal region, then hands, legs, okay, palms, soles. So this will be the appearance. Now, what are the causes for acrodermatitis enteropathica. It's not only zinc deficiency, some other genetic conditions like cystic fibrosis, then biotin deficiency, essential fatty acid deficiency, all these can lead to, the same condition, acrodermatitis. And there are some acquired conditions like acquired zinc deficiency, as you see in pregnancy, then burns, you tend to lose zinc, then kwashiorkor, certain drugs, then necrolytic migratory erythema, then iatrogenic, where you are restricting protein, all these can lead to, all these could be the acquired reasons for acrodermatitis enteropathica. Okay, so these also you can expect as answer, because zinc everyone knows, other conditions also can lead to this particular disease. So you remember these as MCQs. A patient presented with bleeding gum, brittle nails, and wobbling of teeth. What could be the reason for impaired wound healing in this patient? There is bleeding gum. So you may think vitamin K. No. Look into the other manifestations. Brittle nails, wobbling teeth. And the question is, what is the reason for impaired wound healing? Is it vitamin K? No. These are the classical features that you see in scurvy, right? These are the classical features that you see in scurvy, and scurvy is because of deficiency of vitamin C, right? It is because of vitamin C deficiency. But do you find that answer here? No. So what is the answer here? Vitamin C deficiency can lead to decreased collagen synthesis. And that is the answer here. Because of decreased collagen synthesis, there is impaired wound healing. Don't you know that for wound healing, you require collagen? And collagen synthesis, in collagen synthesis, vitamin C plays a major role. Okay. So, like I said, vitamin C plays a critical role in the maintenance of normal, mature collagen network in humans, and it has some anti-scurvy properties. So, it prevents the auto-inactivation of lysyl and propyl hydroxylase, which are two key enzymes in the collagen biosynthesis. So, I think this is a repeat question. This collagen biosynthesis, lack of collagen synthesis, vitamin C, this is a repeat question. All these are repeat questions, but asked in a different, in a little bit twisted manner. Polished rice is deficient in which of the following vitamin? When you polish, the outer layer is lost, and outer layer is rich in lot of vitamins and minerals, and that vitamin which is very critical and lost, which can lead to a disease known as beriberi. So, beriberi is because of vitamin B1 or thiamine. Vitamin B1 is thiamine. Okay. So, white rice, brown rice, which is good or better, or which one has got more nutrients or nutritious value? It is brown rice. When you polish, rice loses many vitamins and minerals through the bran, the outer covering, and that outer covering is rich with minerals and vitamins, and the most important nutrient of this is thiamine or vitamin B1, and it can lead to beriberi. Beriberi is a MCQ. Okay, beriberi is an MCQ. So from B1 we have got beriberi as well as, do you remember, Wernicke-Korsakoff psychosis? So two questions came from vitamin B1 itself. So when you polish rice, it strips the outer layer, that is the bran is removed, and thereby vitamin B1 is also removed. Which of the following vitamin causes dermatitis, dementia, diarrhea? Okay, I think no exam goes without this question. Sure question. Just study this, definitely you will get 4 marks. Okay, so this is, here the answer is vitamin B3 or niacin. The answer is niacin. And niacin, last year the question was, this was the question last year. Identify this. This is Cassell's necklace, right? This is Cassell's necklace seen in pellagra. So, pellagra is because of vitamin B3 deficiency, and it can lead to certain manifestations which are starting with 4 Ds, right? Which are those 4 Ds? 4 Ds are dermatitis, diarrhea, dementia, and possibly death. Okay, even that is also possible. And what you see here, it can, pellagra can lead to photodermatitis, but you know, in severe cases, sometimes there will be hyperpigmentation leading to scaly lesions covering the back of the hand and wrist, leading to a condition like this. What you see here is known by a name, known as, see, this looks like the metallic glove that, you know, the soldiers used to wear. What is it known as? This looks exactly the same, so it is known as, the glove is known as gauntlet. Okay, so this is known as gauntlet. Gauntlets, sign of pellagra, seen in certain cases of pellagra. Okay, gauntlet sign of pellagra. Okay, so with this we have discussed. Another commonly asked MCQ from pellagra is, what are the risk factors which can lead to pellagra? There is one food and one medicine. Medicine is INS therapy, can lead to pellagra. Next, eating corn or maize or jowar can lead to pellagra. So these are frequently asked MCQs. Every year you can expect at least one from pellagra. A study was done to know the association between aniline exposure and blood cancer. They selected aniline dye users from 20 years back using records and compared them with the then office workers, followed both the groups for 20 years. On seeing this question, I was so happy. At least one question came from epidemiology. All other questions were from nutrition and vitamins. And this is not that simple question, but those who have attended class might get the answer very fast. What is it? By the way, what is the question? It is to know the association between aniline dye and blood cancer. Now, how are they doing the study? They are doing the study by collecting the records which were kept 20 years back. And based on the records, they are actually dividing the patients into two groups. Or, I'm not calling them as patients, you know, people into two groups. A group that was exposed to aniline dye, another group which was not exposed to aniline dye. That is what you mean by office workers. Okay, office workers. Then, from 20 years back, they are following both the groups. So, you have an exposed group that is exposed to aniline dye, unexposed group, a group that is not exposed to aniline dye. From there, they are being followed up till today to know what percentage of exposed group have developed blood cancer as of today and what percentage of those who were not exposed to aniline dye have developed blood cancer after 20 years. That means today. So, what is it? There is a follow-up. So, this is obviously cohort. Okay, obviously this is cohort. But which cohort? Don't you know we have mainly three types of cohort, right? You have prospective cohort, you have prospective cohort, then retrospective cohort and ambidirectional. Prospective means you are taking exposed, non-exposed, you are following them into the future. From today, you are following them into future for another, 20 years or 10 years to see what is happening. That is prospective. Retrospective means, as the name indicates, there is a retrospective component. That means you are selecting these exposed and non-exposed from the past using some records kept. Okay. And ambidirectional means those who were started from the past till today, if they are followed into the future to see how many more inexposed and non-exposed will develop these outcomes in the future, that is ambidirectional. That means, ambi means two, right? Or this way and that way. So, this is prospective plus retrospective. So, what is the answer here? It's very, very clear. Here the answer is retrospective cohort. Now, few students ask me, ma'am, can't it be case control? Because already the outcome have developed, then why it is not case control? By the way, guys, what is case control? In case control, you are starting with the diseased and non-diseased. Okay, if you are taking patients who develop blood cancer, patients who did not develop blood cancer or those without, that particular condition. And if you're asking them about their aniline exposure, then you can say it as case control. But here, the scenario is completely different. See, follow up, follow up. From there, you're starting with exposed, non-exposed. So that makes it cohort. Okay, so that makes it cohort. You are not starting with diseased and non-diseased. Instead, you are starting with the exposed and non-exposed. So clear. Nothing to think. It's very, very clear, very evident. So next question. Next question is from diseases. Okay, epidemiology of communicable diseases. There were, I think, 3 questions. One is chickenpox. An outbreak of chickenpox has occurred in a boys' hostel. What will be the next line of management for cases and contacts? See, whenever there is a disease, especially an infectious disease, you have to take care of both cases as well as the contacts, right? So, what will you do to case? You have to isolate the case. You have to physically separate that case. For how long? Till this person can give disease to another person, or during the infectivity period, this person should be kept alone. So, isolate for 6 days. Okay, because the infectious period is usually 6 to 7 days. So, you have to isolate them for 6 days. Along with that, you have to give treatment, which is a drug. There are many drugs, of course. There are many antivirals, but the one that we normally use is acyclovir. 800 milligram 4 or 5 times you have to give. Okay, and what to do to the contacts? Contacts, they don't have disease, but you have to quarantine them. Okay, for how long? For 14 days. You have to quarantine them for 14 days. That means you have to restrict them for 14 days. And what is the importance of 14 days? That is a maximum incubation period, because you want to see whether they will develop the disease or not. So, you quarantine them for 14 days, and along with that, you have to, it's better if you start them with immunoglobulin as a prophylactic within 72 hours. So, which is the answer? This is the answer. Isolate cases for 6 days with acyclovir, and you have to give immunoglobulin, varicella zoster immunoglobulin, within 48 to 72 hours for the contacts. Now, let's see the control measures. You have to notify the case, then you have to isolate the cases for 6 days after the onset of rash, and you have to disinfect the articles, because fomic transmission is there. Antivirals are, it's not only acyclovir, valacyclovir, then famiciclovir, lots of other medicines are there, but we normally give is acyclovir. Okay, for scarnet, all those are there. Immunoglobulin, it should be ideally given within 72 hours. That is, the next MCQ should be given within. We have already seen all these have already come in this exam within 72 hours of exposure. For the prevention of chickenpox, usually we give this for people who are very susceptible to develop the disease, like immunocompromised people who are on steroids, who are on cancer treatment and such things. Normally, we don't give immunoglobulin. If it is a high exposure and the person is very susceptible, then it is advised to give immunoglobulin. And it is given as intramuscular injection. It is given as intramuscular injection in a dose of 12.5 units per kilogram with a repeat dose of same in 3 weeks if it is a high-risk patient who remains exposed. Another thing that you have to remember is there any chance for immunoglobulin for the cases? No. Okay, it has no therapeutic value in established cases. So, if it is like, if in one of the options, if it is given that immunoglobulin for the cases, no, that is wrong. There is no role for immunoglobulin once the disease has manifested. And then there is a vaccine. We are talking about the control, right? So, vaccine plays a very important role. It is a live attenuated varicella vaccine. Doses 0.5 ml. Next MCQ is given as sub-Q dose. Route of administration is subcutaneous, and the recommended one is 2-dose regimen. Okay, from 1 year onwards or from 2 years onwards, it is advisable to give this prophylactic vaccine to children. And the dose is 2-dose regimen with 6 to 3 months of duration or gap for children between 2 to 12 years. Okay, whereas for those above that age, that means from 13 years to adolescence, to dose, the gap advised is 4 weeks, 4 to 6 weeks. Okay, so for children, small children 2 to 12 years, the gap between two doses advised is 6 weeks to 3 months. It's little more. Whereas for those who are above 13 years, it is 4 to 6 weeks. Okay, now let me ask you one question. Is there any role for vaccine in prophylaxis? Yes. It is also said that if you can give this vaccine within 72 hours of the first exposure to contacts, this can act as a prophylaxis, or this can prevent varicella or chickenpox to a certain extent. So, it is not just immunoglobulin, but you can also give vaccine for prophylaxis within 72 hours. Within 72 hours. Okay. Next question, how to collect water sample from a tap? You may think, oh, it's so easy to answer, but there are 2-3 confusing questions or options. Before taking the sample, let the water flow for 1 minute. Okay. Take water from gentle stream of water to avoid splash. Keep the bottle tightly to the tap to avoid splash. Take water from tap which is leaking. Obviously, that is wrong. Okay, if you use your common sense, we know that this can't be the answer. But you may confuse between A, B and C. This is what I have got from those students who have tried to recollect this. Many have gone for A, few have gone for B, and few have even gone for C. So, what is the answer actually? Here the answer is B, guys. The answer is B. Take water from gentle stream of water to avoid splash. That is the answer. Now, the majority who have gone for A. Why the answer is wrong? I'll show you the guideline by WHO. How to collect? It says that tap should be opened fully and water should run to waste for at least minimum of 2 minutes. You have to keep it open in order to flush the interior of the nozzle and to discharge the stagnant water in the service pipe. So, opening for 1 minute will not work. You have to keep it for minimum 2 minutes open. Are you understanding? I know majority who are listening to this might have gone for first option. Okay, but that is wrong. If the tap is not in regular use, then, okay, so let me tell you, since we are getting questions from collection of water from tap, let's see other MCQs as well. The tap should be sterilized. If it is not in use, that means, a lot of microorganism might be there. So, you have the tap should be sterilized, as you can see. See this one. Okay. It should be sterilized by heating it until it is unbearably hot. Then you won't be able to touch it, right? So, keep the tap open after that so that it will be cooled by allowing water to run to waste before the sample is collected. If it is from regular use, just open it for 2 minutes and then you collect water. If it is not in use, then you have to sterilize it, like you see in this picture. Okay, then you open it so that it will cool down. After that, you take the sample. Now, coming to the other options. As you can see in this picture, the next what you have to do is take the bottle. Then the bottle should be held near the base with one hand and the stopper and the cover over it should be removed together and held in the fingers. Then you keep the sample bottle below the water from an area where there is gentle stream of water coming from the tap to avoid splashing. Okay, you have to collect it from a gentle stream of water. That was one of the options, right? Yes. And don't collect from leaky. That was there already. That was beyond any doubt. From leaky, it is not that good to collect water. Then special precaution should be taken to clean the outside of the tap and to flame it sufficiently to ensure sterility, that we have already seen. Okay, so the answer is B here. Hope you are convinced. Next is again from epidemiology of diseases and its prevention. A clean-cut wound without laceration was found in a male who has taken TT 10 years back. Now, what is the schedule of management regarding TT immunization? Give single dose of TT or give full course of TT? TT with immunoglobulin? No treatment required. Nothing is required, just leave him free. We know that when it comes to post-exposure prophylaxis with TT in a wound, 5 years, 10 years, all these play a role, right? So let's see how you are categorizing the immune category. We have already seen this. All these are previous year questions which we have seen. A, B, C, D. Category A means he has taken complete dose of TT or a booster within the past 5 years. That means less than 5 years. 5 to 10 is B. That means within 5 to 10 years, he has taken complete dose or one booster. Then more than, C is more than 10 years. He has taken complete dose of TT or a booster in more than 10 years. And then D is, we don't know about his TT, his immune status. It is unknown. That means he has either not taken or we don't know his immune status. Okay. So, less than 5A, 5 to 10B, more than 10 is C and nothing known is D. Okay. Now, let's see how to give post-exposure prophylaxis. That again depends upon not only immune category but also the type of wound, whether it is clean or unclean wound. If it is clean, that was a question. For A, nothing is required. Not only in clean, even in unclean, nothing is required. He is, fully immune, whether it is clean or unclean, no problem. Okay, if it is less than 5 years. Then B, that means between 5 to 10. If it is a clean wound, you give one booster dose. More than 10, if clean, give one booster dose alone. And if it is D, that means we don't know his immune status. Okay, then if it is a clean wound, you give complete TT schedule. Okay, you give him complete TT. Okay, is that clear? So, this is how you deal with A, B, C and D category if it is a clean wound. So, clean wound doesn't require immunoglobulin at all. That is the first point that you have to keep in your mind. If it is a clean wound, no role for immunoglobulin. Now, move on to the right side. What if it is an unclean wound? Like I said, for A and B, it's the same. A means fully active immunity, so there is no role for any booster at all. B, 5 to 10 years, give one booster. In both cases, whether clean or unclean, just 5 to 10, one booster. Are you with me? If it is more than 10, okay, and the wound is unclean, that means immunity is little compromised. After 10 years, you can't completely rely on your immunity, right? So, along with booster, since it is unclean, that means it is a high-risk wound, you also give human immunoglobulin, tetanus immunoglobulin. Okay. Unclean wound, immunity unknown, then you have to give, anyway, you don't know about his immune status or he has not taken. So, you give complete for the future as well as one human tetanus immunoglobulin for that particular wound. Okay. So, this is how you give post-exposure prophylaxis. There is no role for immunoglobulin in clean wound. In unclean wound for category C and D, you are giving immunoglobulin. Am I clear? This is a repeatedly asked repeat question. So many times they have asked this question. I remember this coming in INICT, FMG, NEET, in every exam this comes. Okay, so don't take a chance here. Next, confusing question, right? According to NTEP, if sputum AFB is found negative, chest X-ray is suggestive of TB, what is the next best step? What did you write here? Did you write repeat AFP? I don't say it is wrong, but that is not the answer here. Here the answer is do CBNAT. You have to do CBNAT. Because NTP says that if the sputum, anyways, simultaneously you will take the sputum as well as chest x-ray, right? If the sputum is positive, then you don't have to worry, it will be a microscopically confirmed TB case. If sputum is negative and x-ray shows signs or symptoms of TB, or if the doctor has a high suspicion that it could be a case of TB, then you have to, along with repeating sputum, you have to do CBNAT. And the treatment or your further procedures or what you do next or your management depends upon the result of CBNAT. So, the best thing that you have to do is, you have to do, see, you never do, I mean, I'm not saying that this is wrong, but the best is you do CBNAT, because NTEP says that you should do CBNAT, and the management depends upon the result of CBNAT. Now, I'll show you the picture. This is the diagnostic algorithm which is there in your Park textbook, and this is from the site of NTEP. Okay. And as you can see, you take smear, you do smear examination as well as chest x-ray. If smear is positive, hope you can see here, it's, of course, a little, I mean, it's not that clear, but you can make out, right? It's there in your Park textbook. If you can't see here, just to open your textbook, it is there in your textbook. Okay. If the smear is positive, nothing to worry. It will be a microscopically confirmed TB cases. Then smear negative, but chest x-ray is suggestive of TB. Or smear is negative, chest x-ray is also negative, but the doctor has a high clinical suspicion. In both those cases, the one that is suggested by NTP in the algorithm is go for CBNAT, because the treatment depends upon CBNAT. Okay, the best test is CBNAT or simply NAT, because we have now CBNAT as well as true NAT. We have two types of NAT which we have discussed in our class. Okay, so this is the latest algorithm, and the answer, the best approach next is doing a CBNAT. Okay. In a PSC, a pregnant woman avoids taking papayas, thinking it as an abortifacient. Who should pay frequent home visits to counsel her about nutrition? Another confusing question. Not that much confusing. The question is, who will go to her house frequently to tell her that it's good to take this fruit, you don't have to avoid this fruit, this will not cause abortion? Who will visit her house and regularly counsel her? It is Asha worker, right? Asha worker. She is the one who is selected from the community and who should pay regular visits to counsel her, the pregnant women, not only pregnant women, but all people about nutrition. Anganwadi worker also does the same, but she is not doing frequent home visits. Whoever comes to her area, she will counsel them. Whoever comes to Anganwadi, she has to give counseling regarding nutrition. But frequent home visits will be done by Asha. And I specifically asked students whether this was there in the question. They said, yes, ma'am, frequent home visits were there. Then the answer would be Asha. Okay. Now, what are the roles and responsibilities of Asha? This is from the NHM side, to create awareness on health and social determinants. You know that. And she mobilized the community towards local health planning. Then she also gives little bit of curative care, right? Asha is, the functions of Asha is an important MCQ. Then she will take steps to create awareness and provide information. Create awareness, provide information in community on the determinants of health such as nutrition, basic sanitation and hygiene practices. Okay. Then she counsel women, birth preparedness, importance of safe delivery practices, breastfeeding and complementary feeding, immunization, contraception, STI prevention, all these are coming under the roles and responsibilities of ASHA worker. Okay, so nutritional advice to pregnant women after doing frequent home visits is done by ASHA worker. And she also mobilizes community and facility. We have already discussed all this. Okay, so immunization, antenatal checkup, postnatal checkup, ICDS, all these are coming under, see, ICDS means Anganwadi, and ASHA is helping Anganwadi worker to do it. She will work with village health and sanitation committee. Then she will arrange escort, accompany women and children for treatment to PHC or CHC. Okay, so these are the roles and responsibilities of ASHA. Next question is from maternal and child health. A 7-week-old asymptomatic pregnant lady came for USG, and during that visit she was found to have a hemoglobin of 9 gram per deciliter. What advice will you give regarding iron intake? That means iron folic acid. What is your answer? When will you start is a question. By the way, first question, when will you ideally start iron folic acid? In 2nd trimester, right? But what is the condition here? That is given for prophylaxis, that means to prevent anemia. Here the hemoglobin is 9 gram per deciliter. Can you comment about the anemic status of this lady? Is she anemic or not? Tell me, what is the cutoff for anemia? 9 is very obvious. You may think anemia single digit, so it has to be anemia. But what is the cutoff? Cutoff is, what is the cutoff for anemia? In pregnancy, it is less than 11 gram per deciliter. That is anemia. That is a definition for anemia. So this lady is definitely anemic, right? That means from 10.9 to below, it is anemia. So she requires iron at the earliest. That means you have to start from, she's already in 7th. So you start. The best answer is you have to start immediately. That means start at 8 to 10 weeks. Hope I am clear. You don't have to wait because she's already anemic and the child is growing inside. So there are high chances that child may go for some complications. So you give iron at the earliest. It is 8 to 10. Next MCQ. I hope you know the dose and all. How much is the dose of iron folic acid that you give in pregnancy? Iron folic acid. Iron is 60 milligram of elemental iron and folic acid is 500 microgram or 0.5 milligram. Next MCQ. How many should be given? 180 days every day, right? 180 days in the antenatal period and 180 days in the or after delivery up to 6 weeks. Okay. Is it clear? So this is how you give iron folic acid and the color is red. All these are MCQs. A patient presents with high grade fever, chills and rigor. On doing rapid diagnostic test, HRP2 was found to be positive. Which of the following species must be responsible for this malaria? It's clearly written, it's malaria. Even otherwise, you know, high grade fever, chills and rigor, malaria. So the question is, the RDT kit found HRP2 as positive. So which among the following is the species that has led to this malaria? So you know, we have Plasmodium vivax, falciparum, then ovale and malaria. Which one will give you HRP2 positive? It is falciparum. Okay, now let's see few more other points from this particular topic. You know, when you do rapid diagnostic test for malaria, the kind of or the methodology that you employ is immunochromatographic method. That is the first MCQ. And it detects malarial antigens in the blood, in the peripheral blood. So, immunochromatographic is an MCQ. This is an MCQ. I have already said that in my class. Then antigen detection is also an MCQ. And antigen includes, see, there are mainly three types of proteins. One is you have histidine-rich protein or HRP2, then you have aldolase, and then you have LDH, of which the MCQ is HRP2 will be positive in falciparum. HRP2 will be positive in falciparum, whereas LDH is for non-falciparum. LDH positive will be mainly for, actually LDH is positive in all the four, but when you get HRP2, that will differentiate falciparum from non-falciparum. Okay, so this will be positive for all four, whereas this will be positive only in falciparum. That means HRP2 positive means it is falciparum. HRP2 negative means it is non-falciparum. Are you getting me? Okay. And when you see non-falciparum, it is difficult with your RDT kit to differentiate whether it is ovale or malaria or vivax. But normally what we see in high prevalence in India is vivax. So you don't have to think much. Anyway, the treatment, everything is the same. Okay. So HRP2, falciparum, that is the MCQ here. Confusing question. Wife of a truck driver presents with vaginal discharge and cervical erosion. Which kit is given to her for treatment? When I asked students, they straight away told me, ma'am, it's green, or kit 2, it's green. But after, discussing a lot, they found, oh, cervical erosion. So it could even be, cervical discharge. Some said cervical discharge. Then some said cervical ulcer. So they were again confused. It could be grey kit because cervical discharge is there. Some said it could be PID. So again, some other kit. But what do you think is the correct answer? Majority, I would say around 95% of recollection was exactly this question. There was vaginal discharge and they said, ma'am, it was not cervical discharge or cervical ulcer or any other cervical lesion, but cervical erosion was the term given. Okay, if this is the question, please do remember that cervical erosion is something normal. It is a physiological thing that you see in, reproductive age group. Okay, so it is not a disease. Cervical erosion is something normal. That means something that you commonly see. I'm not saying normal, but something that you commonly see. Okay, something that you commonly see in reproductive age group. And one of the manifestation of cervical erosion is vaginal discharge. Are you with me? Okay, so it is vaginal discharge and cervical erosion. So the answer is kit 2, which is green. Okay. So this is what majority of students have recollected. So the answer I will say is green, which is kit 2. Okay. I hope you know this, right? You have grey and I have even given a mnemonic to remember it in the class. So you have grey kit, which is for cervical discharge and urethral or anorectal discharge. Then you have green for vaginitis or vaginal discharge. Then you have white, genital ulcer. Then you have blue, genital ulcer, non-herpetic, to those patients who are allergic to penicillin. Then red for genital ulcer, herpetic. Then PID. This was the answer some had thought, because if there is cervical ulcer, then there is, vaginal discharge, it could be PID. Then yellow, then inguinal bubo is black. So from the recollection of majority of students, I would go for green. Okay. And these details also we have already gone through in the class. So let's go to the next one. Very simple question. Very, very simple question, which you know right from your UG time. This used to be a short note, right? Children with low BP tend to have low BP as they grow up. Yeah, that's true. Children with high BP tend to have high BP as they grow up. So what do you call this phenomenon as? This phenomenon is known as tracking of BP. This is known as tracking of BP. See, you're tracking BP from childhood till the, till they become adults or maybe elderly. And this is the picture given in your Park textbook regarding tracking of blood pressure. As you can see, along the y-axis you have blood pressure and along the x-axis you have time in years. And those with low pressure, low BP tend to have, or they continue to have low BP once they become or once they grow up. Those with high, see, it tends to be high. Okay, so if you can track from the childhood, you may get to know who are high risk and who are low risk. So this phenomenon is known as tracking of blood pressure. And rule of half, that also we have already discussed, and stepwise approach also we have discussed, step 1, step 2, step 3, step 4, to find out the prevalence of risk factors in NCD. I am not going into those details, please refer the class. White fingers in industrial worker is due to, I couldn't get all the other options, but white finger, that means repeated pressure, white finger, vibration, repeated vibration, it is because of vibration. Okay, in automobile workers and those people you see this, okay, people who use hammer. So white fingers in industrial workers is because of vibration. I really couldn't get other options. Anyway, the answer, vibration was there in the option and this is the answer. DEC provocation test is done for diagnosing. If you know what is DEC, definitely you would have answered. It's a very simple question which we have discussed. DEC, diethyl carbamazepine, is for the treatment of filariasis, and DEC provocation is a test done for diagnosing filariasis. Right? Now let's see what it is. See, usually in filariasis, you are taking the blood and you are trying to show the presence of microfilaria in blood. But in mostly the microfilaria, they have something known as nocturnal periodicity. That means at night they tend to come to the peripheral blood. So when you take night specimens, you are more likely to get a positive result, whereas you are likely to miss a positive result for microfilaria when you take blood samples in the daytime. So usually you have to go for night blood specimens. This is how we were doing it. And DEC, that means the full form is diethyl carbamazepine. Carbamazepine is a provocative day test to find out or daytime diagnosis of Butyria bancrofti in areas where the microfilaria show a nocturnal periodicity. Okay, and DEC, it is a drug which is given for the treatment of filariasis, and what it does is it flushes out the microfilaria into the peripheral circulation. So in this DEC day provocation test, you are actually provocating the microfilaria to come to the peripheral blood during daytime. And what you do here is, you are giving 50 to 100 milligram of DEC to the patients, and in 30 to 45 minutes, the microfilaria will come to peripheral blood. Then you take the blood and you will get positive result. And it is as sensitive as taking night blood sample. So DEC provocative test is to diagnose microfilaria in the peripheral blood during daytime. Okay, and what you give is 50 to 100 milligram of DEC. Are you with me? Okay, it's a very simple one. DALI. Again from epidemiology, this also we have discussed 1,000 times. Okay, DALI includes YLL plus YLD. By the way, what is DALI? Disability adjusted life years. And I said DALI is YLL plus YLD. And the question was, what does YLL represent? YLL, DALI, disability adjusted life year, is YLL plus YLD. What is YLL? YLL is years of life lost to premature death. YLL is, this is YLL. Then what is YLD? YLD is years of life lost because of disability, or years of life lived with disability. Okay, so this is years of life lost to disability, or how many years the patient lived with disability is what you are trying to find out in YLD. Okay, so YLL is years of life lost to premature death. So that brings us to the next question. What do you mean by premature death? Premature means someone, as the name indicates, someone who is dying prematurely. That means even before reaching their normal life expectancy. For example, suppose the life expectancy of a country is 65. That means the normal life expectancy of a person is 65. He is dying at the age of, say, 45 years. How many years he lost because of premature death? 20 years. 20 years. Hope you're with me. Okay, so this is YLL, years of life lost to or due to premature death, and YLD is years of life lost because of disability or years of life lived with disability. So, DALY measures, this we have already seen, life lost due to premature mortality, that is YLL, and years of life lost due to time lived in less than full health or in disability. So, just remember D is disability. Okay, D is disability. Again, another question from nutrition. RDA serves the need of what percentage of population? Another repeatedly asked repeat question. And you know the answer. RDA is recommended dietary allowance. And recommended dietary allowance is for satisfying the needs of what percentage of population? 97.5% of population. This we have learned as such many times. Okay, RDA is for satisfying the needs of 97.5% of people in that population. The rest 2.5 will not come under RDA, they may have some other requirement. So, you can't satisfy all the 100%. There may be some people who are very much away from the normalcy, right? Okay. Recommended dietary allowance or RDA, it is the average daily dietary intake that is sufficient to meet the need of nearly all. Nearly all is also an MCQ. Nearly all means 97.5. Okay, healthy individuals. Then how do you calculate RDA? That is another MCQ. Average plus 2 standard deviation. Average is EAR. That means estimated average requirement is average. That means what is the need for 50%? Around 50% is average. That plus 2 standard deviation will include 97.5%. So, RDA is, that is the next MCQ. This is also an MCQ. Average plus 2 standard deviation. I hope you remember normal distribution curve. I had no intention to go into those details, but just for completion, in case you have any doubt. This is normal distribution curve, right? And this is the average. You have mean here or the average here. Then 2 standard deviation will cover plus or minus, plus 2 standard deviation here, minus 2 standard deviation here. That will cover 95%, right? %95% of population, right? So, here you have 2.5% outside and you have another 2.5% outside. So, your RDA includes actually this much. Okay, from here. So, this is 2ST plus 2ST minus 2ST. Okay, so below this minus 2ST you have 2.5% of population, and above this plus 2ST you have 2.5% of population. And your recommended daily allowance is for those who are below plus up to here. Okay, that means it covers 90, I think you are unable to see. Now can you see? Okay, 97.5% of population. So, only this 2.5% is outside your RDA. Okay, are you with me? I really want to go into the details, but this is a recall session, so I am not going into those details. Just go back to the class. class videos will tell you more details. Which clinical manifestation will be absent in a typical case of heat stroke? This you might have learned in medicine as well as in community medicine. In heat stroke, we know in typical cases of heat stroke, no sweating. No sweating. Whereas there will be high rise of body temperature, loss of consciousness, convulsion, and it's a fatal condition. It's a fatal condition where the body's regulatory mechanism, temperature regulatory mechanism is compromised or affected. So in heat stroke, it is due to failure of heat regulating mechanism. That is the first MCQ. Characterized by high body temperature. It may rise up to 110 degree Fahrenheit, which affects the brain, leading to delirium, convulsion, and partial loss of consciousness. All those were there in the option, right? Skin will be dry, hot. Classically, see, sweating is absent or diminished. You don't have to think much. This is a frequently asked MCQ. Not once or twice, many times. This question was there in previous MCQs. Which is the classical feature? Which among the following will be absent in heat stroke? It is sweating. The outcome is often fatal. And how do you treat it? You have to treat them by cooling the body in ice water till the rectal temperature. How do you monitor? You have to monitor the rectal temperature. It should fall below, till it falls below from 110 up to 102 degree Fahrenheit. Okay. And I'm not going to the rest of the details. You have to see by monitoring the rectal temperature that the patient will not go for hypothermia. Okay. So this is a expected MCQ. Another MCQ which we have learnt many times, which is the best parameter for assessing health status of a community. It is IMR. It is IMR. Not MMR, not poverty index, not HDI. HDI is human developmental index, but IMR. Do you remember? I'm showing you the same slides. Okay. Single best indicator of socioeconomic development of a country is IMR. There are lots of MCQs from IMR. IMR is the best for so many things in the community. Then most important indicator of health status of a community is again IMR. By the way, what is IMR? That is infant mortality rate. You know that, right? Okay. Level of living of people in general is given by IMR. Effectiveness of MCH services, how good are MCH services working in a community is given by IMR. Largest single age category of mortality is IMR. So I have already told you IMR is the answer for a lot of questions in MCH. So if you come across a question where IMR is there in the option and you are not very sure of the answer, if you go for IMR, you are more than 50% likely to be correct. I've said it back then, now also I am saying. Next is a very, very simple question and very much expected question from Universal Immunization Schedule. Every year one question comes from Universal Immunization Schedule, right? Here the question is, a child studying in 5th standard, which of the following is a vaccine given as per UIP? Which is a vaccine? See, I have a request. Don't just go by this number 5. I'm telling you, this has occurred to many. You will only see the number. Then you will think, okay, what is the vaccine to be given to a 5-year-old child? It's not 5 year. It is 5th standard. What is the age of children in 5th standard? They'll be around 10 to 11, I would say. 10 to 11. So the question is, which is the vaccine that will be given to children in 10 to 11 years old or who are in the age group 10 to 11 years? Which is it? It is TD, right? Earlier we were giving TT, but now in UIP there is no TT. Instead we are giving TD, capital T, small d. Okay. Now I'll show you something. I know you will be complaining now, ma'am, we can't see. Of course, I know you can't see, but this is a picture taken from your Park textbook. Okay. And I want to tell you that the latest immunization schedule is there in Park textbook. So please read it. Okay. Now, you know, DPT, when it comes to DPT or pentavalent, it's given during 6, 10 and 14 weeks, right? After that, at 1.5 years, you give, approximately, 1.5 years, you give 1 DPT. This is penta. Then 5 to 6, it is DPT. Then 10 and 15, these are, approximate numbers. 10 and 15, it is TD vaccine. And this is a frequently asked MCQ. You should be knowing. Okay. Which of the following is provided in India as per Colombo Plan? Totally unexpected question. I have never mentioned about what is Colombo Plan anywhere in my class. I'm sorry, because no faculty, I don't think any faculty would be expecting this question, because Colombo Plan is something which happened long back in 1951. So, no one was expecting any question from Colombo Plan. Anyway, this has come, unfortunately. So, let's see what is the answer. Colombo Plan. Which of the following is provided in India as per Colombo Plan? It is cobalt. Cobalt supply. Cobalt supply is the answer. Okay. I am not expecting any question even in future. Maybe the same question can get repeated. So, Colombo is for cobalt supply. Now, what is it actually? This is a cooperative. This is a plan for cooperative economic and social development in Asia and Pacific countries. Okay. And this dates back to 1951, and this was established by Australia, Canada, India, Pakistan, New Zealand, Sri Lanka, United Kingdom, and currently 28 countries are there. Actually, the question was from I would say a lot of things were done under Colombo Plan in India. But pertaining to the MCQ that we got for this NEET 2023, let me tell you what exactly are the details pertaining to that particular question. So, super voltage radiotherapy was first started in India with the installation of cobalt unit in various centers. The input was mainly from the establishment of cobalt units under Colombo Plan, when almost 15 units were established. When 15 units were especially donated for the development of super voltage radiotherapy. So, this is from the history, this has something to do with the history of radiotherapy, where around 15 units of cobalt were supplied by Colombo Plan. Okay. And the main country behind this was Canada. A lot of countries were there, but in these cobalt units were mainly provided by Canada. A premature baby has low birth weight, decreased hearing, congenital cataract, and PDA. What is the most likely cause for this? Whenever you hear PDA, cataract, obviously that syndrome will come to your mind. Which one? Congenital rubella syndrome. And in congenital rubella syndrome, the triad is cardiac defect, then congenital cataract and hearing loss. Right? Congenital rubella syndrome. Let's see a few more other MCQs from CRS or congenital rubella syndrome. This we have already seen. There will be sensory neural deafness, cardiac malformation, cataract, and other symptoms are also there like glaucoma, retinopathy, microcephalus, cerebral palsy, IUGR, hepatosplenomegaly, mental and motor retardation. Because there was one question earlier, guys, from this. Microcephaly is seen in which of the following conditions? Okay, congenital conditions. And congenital rubella syndrome also was there in one of the options. So, please do understand microcephaly is possible. One was Zika, except 3. One was a condition where microcephaly is not seen. So, in CRS, microcephaly is also seen. That is what I want to put across. Then, coming to rubella vaccination. MCQs from rubella vaccine. The name of the vaccine is RA273. Previous MCQ. So, rubella vaccine is starting from with RA273. Whereas for yellow fever, do you know? It is 17D for yellow fever. These two are favorite questions. Yellow fever, it is 17D. Next is vaccination strategy. If you really want to eliminate rubella, what is the priority group that should be given or targeted first for rubella? It is first you have to protect women of childbearing age group. That means 15 to 39 years. After vaccinating women in the reproductive age group, then you go to children between 1 to 4 years. Okay. See, this is the group that is likely to give birth to the first group. They are the ones likely to give birth to congenital rubella, babies having congenital rubella, right? After vaccine, you so first vaccinate all of them. Then you target the second group, that is 1 to 14 years. Then all children at 1 years of age. Then go on with your routine vaccination of all children up to 1 years of age. Okay. So this is the vaccination strategy or the priority group. So this is first group, second group, third group, fourth group. This also was a previous MCQ. Okay. A neonate is found to have, again, congenital hydrocephalus, intracranial calcification, chorioretinitis. You will not go wrong here. What infection would have led to this? It is congenital toxoplasmosis. So the answer is Toxoplasma gondii. And you know, if you look at the pathophysiology or if you look at the, the cause, the culprit mainly is the cat, or cats are the main culprits in toxoplasmosis. So how does a mother get it and how does the vertical transmission happens? A fetus may get toxoplasmosis through transplacental connection with its infected mother, right? And as you can see in this picture, how is mother getting it? By improper handling of cat litter or ingesting contaminated meat, having the tissues which have this Toxoplasma gondii. And then in the form of oocyst, it is getting transmitted to the mother, and from mother through placenta, it is reaching the baby. And please do understand that it's not, though we say cat is the definitive host, it's not cat only. There are some other intermediate hosts like you see here. Okay, other animals can also act as intermediate host. And the manifestation, the typical triad is cerebral calcification, then chorioretinitis and hydrocephalus. Okay, so that is the triad. And there can also be jaundice in newborn and hepatosplenomegaly. All these are possible. Okay, so that finishes the MCQs from March 5th exam on NEET 2023. Hope you have got an idea about what were the answers, because I know I too accept that there were a lot of MCQs which were kind of tricky and kind of confusing, but I think by now you might have got an idea of what is the correct answer.